The objective of this little presentation is to talk to you a little bit around what these different kind of conversations might look like. And just to say, there's a massive amount of information that's been provided this morning, and I hope that people are able to start pulling that together. This afternoon we're going to have a lot more time to actually look at how people might put some of this work into action. As Penny so aptly stated, that in the coaching for health context, when we're looking at increasing performance, we're really looking at self-management. And we can talk about health coaching releasing people's potential to work towards maximising their own health. Many of you will know of John Whitmore, who was one of my teachers, who used and coined this phrase about coaching being about maximising people's performance, and certainly in the health context, taking care of someone, or someone taking care of themselves, is that application. So health coaching as a general set of ideas aims to help people raise their awareness while increasing their responsibility for their health. And we're finding that clinicians find that a very useful frame of reference. You can see there are lots of different definitions. Penny made the point that there's a need to actually start getting clearer around what this concept means and what the different contexts mean. Health coaching's become a bit of an umbrella term for lots of different theories, lots of different ideas, and hopefully we'll start working towards clarifying some of that. And we find wonderful definitions like this, Van Ryn and Heaney, and for me the most interesting thing about it is the year in which it was written. So I think it's a great definition, by the way, but if we think about it in terms of this concept is not new, it's not something that we just made up last week or that Penny and I made up over a glass of wine. This idea of health coaching and actually helping patients become more activated in their care and utilising coaching skills to do that has been around for a long time. In Australia, I used to run OSCE stations 20 years ago with fourth-year medical students, helping them to use a coaching conversation with patients. So again, it's not new. There's plenty of evidence out there that this works, and I really support the ideas that Sue and Alf presented around getting on with it. There are lots of, as we said, lots of different emerging ideas around this, and getting clear around definitions seems to be very, very important. So if we break it down, we could say that effectively this health coaching approach is about supporting a person to change their relationship to their health. People with long-term conditions are not going to necessarily get rid of their condition. So it's about changing their relationship through tapping in people's potential for self-care, raising their awareness and responsibility, supporting them to actively self-management, and increasing their confidence and motivation to act. It requires a different kind of conversation from that which clinicians often do use. It requires people to start working in partnership and transforming the client or the clinician-patient relationship and incorporating a number of the skills from health psychology and motivational and interviewing, for example, and different coaching skills. I used to work at a place called the National Centre for Education and Training on Addictions in Australia, and we were extremely good at getting people motivated for about 2 days. And it's not until we actually started layering in these coaching techniques to support people over time that we actually saw a shift in behaviour. It's very useful. We know it's pretty useful in improving lifestyle, reducing health risks, chronic disease management, medicines management, decision support, and it really is about increasing health-related quality of life and improving patient experience. That's all well and good, but unfortunately, this is more what the consultation dynamic tends to look like. And you probably can't read it from where you're looking at it at the moment, but you'll be seeing in the notes later. It seems that by far and away, the biggest dynamic that seems to occur between doctors and patients, while it's really great to have a health coaching model, is one of fear. So the Health Foundation produced a publication last year where really, when we really analysed what was going on, patients are frightened when they come into healthcare settings, a large proportion of the time. They're concerned about if they're going to say things correctly. They're worried about whether they have the right to be there. There's a concern about, do I find out good news or bad news? And clinicians also are suffering from this position of fear. Am I going to actually get the information I need from this person in the limited time frame, shut them up so I can actually get on with telling them what they need to do? Okay? Overwhelmingly, concerned about, do I get it right in the consultation? Am I following the right guidelines? Am I using resources appropriately? So if this is where we are at the moment, we do need to look at helping people actually get to those different consultation frameworks and skills. And Coulter really, again, Angela Coulter's work is really foundational in this area. It's about really helping people come into partnership with this approach. What we've found through the various experiences that we've had is that all of this requires a substantial, significant mindset shift. So helping people to really reflect on and think differently about the beliefs they're holding about patient care, the beliefs that people are holding about their role as clinicians, doctors, and various other health practitioners. And what we've found seems to work really well in training around this and actually helping people establish the mindset shift that we're focusing on is bringing together the principles and models from health psychology and behavioural medicine with the skills and techniques of performance and development coaching. Also finding ways to make that fit in with the knowledge and skills of health practitioners. And as Alf made the point really clearly, it's so important that this is theory-based. There needs to be, it can't just be a made-up idea. There needs to be the actual theory behind this. And we know there's so much from behaviour medicine and health psychology that we can use. Behaviour change theory, as Alf said, what mechanism are people using to have the conversation with? The idea of bringing in some of the ideas around goal setting, ranges of approaches, awareness and responsibility in performance coaching, and then linking that to the diagnostic and consultation, questioning and listening skills that clinicians already have and are usually already trained in, but having those conversations differently. And if we think about some of the key features of the conversations which tend to be useful in helping produce the mindset shift, just really a very quick tour of them. Working with goals, we found that challenging clinicians who really do care about their patients and the interactions that they're having, through asking them important questions about how effective are their conversations? Are they getting outcomes with patients? What's the value of setting a goal? Getting them into the habit of setting goals with patients. Helping people to think differently about how they see their patients. We've introduced this concept of bifocal vision, being able to see what's actually happening at the moment while at the same time seeing what's possible. So not just being stuck in the current behaviour, but seeing patient as resourceful and the holder of the solution at some level. Also being able to flex the style, as Penny mentioned. So most people have their own style and it tends to be somewhere on this range of approaches. And clinicians tend to develop something that works. And usually it's something that works in relation to the various system challenges that they have to deal with. So most of the time people say that they end up being a lot more directive than they want to be. And in fact, we can release a lot of potential if we access the other end of that range of approaches, being non-directive at times, pulling from people, helping them get activated and engaged in their consultations. Also reflecting on the dynamics that occur in between patient and clinician. So thinking about things like the Cartman drama triangle, concepts from transactional psychology, looking at when it feels like I'm rescuing the patient and what's the impact of that. When does it feel like I'm being victimised or victimising the patient and what the impact of that is, and working with those concepts as well. And just finally, in terms of concepts, bringing in ideas of challenge into the clinical conversation. And this tends to be a real difficulty for most clinicians. It's much easier to keep a conversation safe, comfortable, keeping things easy, and not actually getting much shift. The problem with having low challenge conversations with high rapport is they're comfortable, but there's not much awareness raised. And this is another concept that people find really useful in terms of actually working towards shifting that mindset. In terms of how people think about this, what they tell us, the clinicians that we've worked with tell us that the health coaching approach is really useful in helping develop a set of principles or a mindset, which is useful for most consultations. Okay? A set of skills which are useful for the interactions that people are having, and specific techniques, scripts, or conversation frameworks, ways of interacting, which are not going to be useful for every single consultation, but in a large proportion, particularly when they're behaviour change focused, they tend to be very, very useful for people. We've found that when we're doing the training, it needs to be highly experiential. Clinicians like a fast-paced and challenging environment to work with. They like working with applied and skills-based activities. They want to understand a bit of the principle behind coaching and behaviour change. They need time. It doesn't, I'm really glad Penny said about an e-learning package. It doesn't actually give you the results. People need time, they need opportunities to reflect and apply the coaching experience to very real issues. They need to actually feel coaching working for themselves to feel confident working with others. It's not to say coaching works for everything. Coaching is certainly not a panacea. People have told us that learning to be less directive is very difficult. It's easy to go back to one's own default position in the consultation style. It's uncomfortable to bring challenge into conversations with patients. And it's really hard to keep doing it if your colleagues are not. Okay? And these are very real system challenges that we have. It's hard to sometimes identify which patients to focus on, to invest this coaching approach with, and finding the time, managing time to actually do this well, particularly in view of other responsibilities which are unavoidable. However, it does seem like it's worthwhile. It does seem like people get very good results from this. And I think, you can just look at this list of key themes that people report back to us about the impact of following a coaching approach and bringing that into their interactions with patients. The idea that the patient's resourceful, that's relevant to most consultations. It's not an unusual or difficult concept for people to get. The idea of having partnership with patients, releasing the idea that it is just up to the clinician to solve everything, sharing that responsibility does elicit a great deal of energy, and clinicians are telling us they enjoy their consultations more as a result. So finding out what the patient's goal is really key, being flexible in the approach and using challenge supportively where possible. They're telling us that coaching techniques are broadly applicable for all sorts of behaviour change conversations, and that it is possible to introduce that in the 10-minute consultations that GPs have, for example, or the longer consultations that other clinicians might find themselves having access to. What's interesting for me, and I think probably just to sum up or finish off with this small piece around what the conversations might look like, is that it does take courage to actually try something new. And it seems that when people have the willingness to do that, most clinicians really do have the willingness to do that because they really do care about the people that they're working with. And if they are given the time and space to develop some confidence to try something new, they actually get great results for patients. Thanks very much.